Thank you so much for the invitation. Well, on this occasion, I've had some difficulty in preparing a presentation for an audience of non-doctors. But I mean, this audience knows many more things than me, including on the role of liver transplant. Many of my slides are in English. I have not translated them, but in any case, I'll describe the slides. If you have any difficulties, please feel free to ask. Let's start with some statements. At present, liver transplant is the only definitive treatment for Crigler-Najjar type 1 disease. Then, whether or not it's worthwhile doing this ultimate treatment as compared to other non-ultimate treatments, well, I don't want to dig into this, because I believe it's out of the scope. But the only available definitive treatment is liver transplant. Liver transplant should be done before brain damage, because it doesn't go back after liver transplant. And for this reason, in theory, it should be done at an early age, because you cannot know and foresee if and when there will be brain damage. The OPTN data, I mean, it's a large American multi-center study talking about survival at 1 year post-transplant of 91.7%, which is not that high for a disease in which the liver is healthy. This is a multi-center register that comprises centers with good results and others with non-good results. 1 year is a short period of time, but in general, the survival of pediatric patients after transplantation tends to go down. Most of the risk is in the first 3 to 6 months, and in any case in the first year after the transplant. These are 2 historical articles on liver transplant for this disease. First one is of the Brussels group, 6 patients, and the second one I like to show it here because it is by the group set up in Milan by Professor Gridelli, who was here 10 years ago to talk to you, and I belonged to that group back then. So 6 patients, average age, mean age of 52 months, 100% of survival after transplant. I mean, with 6 patients, it's not meaningful. However, this is just to tell you that monocentric series always tend to have better results than multi-center series for obvious reasons. If you are talking about just 1 center and high volumes. 4 patients in 6 have normal enzymes and school life and social life, and a patient with brain damage caused, or better, that occurred before transplant. This was our series published in 1997 in Milan. 5 patients, no retransplant, 100% of survival, no major surgical complication, and 1 pleural effusion. I'd like to show the table as well. It's a work that is important because we don't have many cases, even though it's published in a minor journal. If we take a look at the registers, we can see that in the European register, if we consider the various transplants made for metabolic diseases, which is a subpopulation of all of the transplants made, Crigler-Najjar has an impact that is limited, 4% in the European series. And if we take a look at the series of our Bergamo hospital, which in any case has a large volume program for pediatric liver transplant, Crigler-Najjar accounts for 5%. 5% of all of the metabolic diseases, not of all transplants. Okay, I'll skip this slide. Now then, metabolic diseases are an area where liver transplant is expressed at best. This is the survival curve of the multi-centric European register that started in 1998. This is the history of transplant in Europe. Today we can do much better, but you can see that the metabolic diseases are in line with the cholestatic diseases in kids up to 2. Bear in mind that this includes both the metabolic diseases in which the liver is really cirrhotic and the results are less good, and also the metabolic diseases with healthy liver, of which Crigler-Najjar is part. In this case, there's no stratification, but the result is even better. And the same holds true for kids aged 2 and above. So, in the title I've been given, they talk about the various technical transplant possibilities. Well, the liver is just one in the body, so it can be transplanted in full. But if we consider the anatomic structure, it can be divided in 2 parts, each of which is functionally independent. Maybe even more than 2 parts, but for sure in 2 parts, like this. And this makes it possible to do some things. Well, if the liver is big, you can throw away the extra portion. We no longer do it because it's a waste. Anyway, this is doable. It can be a cadaver liver. It can be split in 2 and transplanted into 2 patients, or a living donor liver can be split in 2. One part is kept by the donor and the other part is transplanted. The 2 options are split liver and living donor transplant, but the technique is the same, and the notion is that a liver is enough to support the life of 2 persons. So, full liver, living donor liver and split liver. Well, the difference is not based upon the patient, but it's based upon the organs. I mean, there's no technical choice except for some situations. There's no technical choice based upon which you can say that this patient should have a full liver, the other patient just a part of it. But considering that in general the population of the patients who need transplant exceeds the number of organs available, you have to do the best. The best livers, which typically are the ones allocated to kids, should be split. The ones from cadaver donor. Or there is also the option of living donor liver. This is a case of a living donor. The liver has been split. This is to give you an idea of how far we can go. We can also use pediatric donors. This is the small left part. You can see how small it can be with these techniques. The large multi-center series say that the living donor transplant has a survival of the organ, not of the patient, because it's not the same thing. I mean, a patient can be transplanted several times. So the organ survival is higher than full liver or split liver transplant. You can see here that there are cases in which certain techniques shouldn't be done because of the limited survival. This is a series published in 2006 by a Brussels center demonstrating that there was no significant difference. I mean, the curves don't reach the same place, but I mean, there are statistical methods to consider if the difference between 2 proportions of 2 different populations is random or is so big that it is significant. Because if we compare only 2 patients, the difference can be case-related. If we have instead 2 big groups, it's less likely that it is case-related. So, with respect to organ survival, in this study of the Brussels group, the split transplant have a less good organ survival compared to full liver or living donor transplant. But bear in mind that in this study, only 20 split transplants had been made in 20 years, which is too little to have a good follow-up. And this is shown very clearly by the European Register. The centers that have had less than 20 split transplants have a result that is much more limited compared to the centers who've had between 20 and 40 and those over 40. So if you compare a technique for which you have 100 cases with another with 20 cases in 10 years, I mean, that's not appropriate.
And this is, I would say, the best cases ever published. This is the Hamburg group. So 132 cases with no mortality, although a few organs were lost. You can see that the difference in terms of a split, full, or living donor liver transplantations, there is no significant difference. Once again, in terms of survival of the organ after living donor transplantation, well, we have to say that in many European countries, the transplantation is actually done on foreign patients who cannot have access to the cadaver waiting list. So if they need to be retransplanted, they are not. Or these are other patients which are remotely followed, so we don't have so many indications about transplantations. And another aspect is that the ones treating patients who were transplanted with living donor, in a way they consider the organ more important than the one obtained from a cadaver. So when it comes to comparing the survival of the organ, I think it is a kind of biased, so it's not fair because of the reasons I mentioned. And moreover, donors run risks, and I know that parents would, take the risk, but you have to know the risks. Unfortunately, not so many data available because it's difficult to have data about negative results. This is an important study with a revision in literature, and 0.16% of death of living donors were found, which is not that much. However, it is not zero. And there was no significant relationship with the type of graft, so left or right portions of the liver. Another way to compare split or living donor is to compare the center in which most split liver transplantation are done with a center where living donor transplantations are done. So we have 95% of survival of the patient. We can compare it with the cases, in this case, Japanese cases of the living donors in this case, and you can see that the results are more or less the same. So it is quite impossible to say that one technique is better than the other. Of course, with the living donor transplantation, you can better plan the transplantation, and of course, you have a better planning and rather than cadaver transplantation. However, we cannot say there is no evidence telling us that one is better than the other. We only made 2 transplantations with living donors, and an extensive use allows for waiting time, a mean waiting time of 55 days. And of course, the less severe patients can wait even up to 1 year. But we never had death in the waiting list, in the waiting time. We only had 1 death, but it was a child who needed also to have a heart transplantation. We also had another patient who died because of other reasons, and in other cases we need many organs, so not only liver. and one patient died because of traumatism, brain traumatism, and so it was basically an accident. He died during the waiting time. So no child eligible for liver transplantation died while waiting for the liver. This is the waiting time, the waiting list. We have 5 kids waiting for it. We have 1 full liver, 1 2 split right, 2 split left. This is the Bergamo hospital data. The waiting time was kind of different, but at 81, 24, 3 days. So actually something has changed in terms of allocation policies too. Children are not in our follow-up because they moved to another city, I think. So we don't have these kids in our list. However, they are alive, and we have a follow-up of even more than 10 years. Okay, we can skip this slide. So today we provide living donor live liver transplantation to all families. Families are quite motivated when we say that the child is not going to die while waiting for the liver. Of course, we have to study the donator carefully. Sometimes we have a cadaver donator, so we can do the transplantation. We have high possibilities of split transplantation, so we select the donor carefully. So we analyze with care the donor. It happens sometimes that the cadaver liver was available some days before the liver donor, but this may not happen because if the date for the transplantation is set, this person is no longer included in the waiting list for the cadaver donors. Basically, we propose it to all families, but unfortunately, we do it in practice rarely. So it happened only twice in our cases. And another issue is the the partial auxiliary transplantation, so the APOLT. So basically, a part of the native liver is removed and replaced with a segmental graft from a deceased or living donor. This technique is quite difficult, and it has 2 main recommendations. So first of all, in case of liver deficiency, so situations in which the liver is a healthy structure, but unfortunately it is affected, and so the liver can be treated, of course, unless the patient dies before it. So the sick portion can remain in place, and if it is cured, then the treatment can be interrupted and the patient can continue to live with his or her own liver. In the metabolic diseases with healthy liver, we transplant a small portion of the liver. In terms of hepatic function, the patient will use the remaining portion, but the additional new part which has been transplanted will produce the enzyme which is missing in his or her own liver, and so will be useful for the metabolic disease. So we have to have a portion which is large enough to produce the enzyme. So it is complex as a transplantation. We have a few experiences which are very interesting. It is not a perfect technique, and a few problems are associated with it. For example, this first patient died, and Well, first of all, managing rejection is quite difficult because, the reactions are quite complicated to be treated because one portion of the liver is healthy. So sometimes we are too late in the diagnosis of the problem. But however, the results are quite satisfactory. Further evolution is the DLT, so the domino liver transplantation, in which the healthy portion of the liver which is removed can be used for another patient. In a few cases, first of all, when the expected interval before the onset of the metabolic disease in the recipient is longer, or at least not significantly shorter than the expected survival with LT. So this is a first condition. Okay, so we are sure that this is a good condition. A second condition is when the genetic defect in the transplanted liver is expected to be compensated by recipients' extrahepatic organs carrying the appropriate gene. Or a third condition is as a bridge, so for further transplantation. Now, this is one single case which is difficult to be done technically, also because all the conditions are difficult to be found. So it's a patient with a genetic disease, which is not Crigler-Najjar, in which the left portion was transplanted and the donor was the mother of the patient. So the left portion removed from the patient with a genetic defect was transplanted in another patient having Crigler-Najjar syndrome. So basically this patient has two half livers having two different genetic diseases, so each portion produces the enzyme needed by the other portion of the liver. So in this case, theoretically, if these two kids had the same blood group, we could basically make the transplantation in between them, so with no need for donors. So this is really fascinating. Non traduco perché
o eventualmente aumentare la voce. Va bene. Grazie.
Lorenzo D'Antiglia, so the previous speaker, collaborated with me. We wrote a paper, and so we pointed out how difficult it is technically. So we have to bear in mind this. And secondly, of course, it is difficult that the conditions are met. So we need two patients compatible in terms of blood group, having two rare diseases that can be crossed in a way. So all these conditions must be met, and it is really rare. However, the principle is really fascinating. However, what is the weakness of the APOLT? Well, first of all, we have to remember that in the liver we have a vein getting into it. So blood with nutrients arrives into the liver. And we have basically two vessels which are imbalanced. So the flow decreases in one vessel and it increases in the other. And the vessel, one of these two vessels, is crucial when it comes to liver operation. So when we realize the APOLT, so of course, we transplant the liver. We may have inflammation, or we may have some situations in which the blood goes to the healthy portion, and the ones which are not so healthy may be affected. So one solution, in a way, is to, for example, narrow the portal vein, feeding it in order not to worsen the situation in the transplanted liver. So this could allow, so this technique in the future, if we use a gene therapy, well, we could basically remove the immunosuppression. However, we would have a narrowed portal vein. So this is the major weakness of this technique. What are the complications experienced by patients? Well, potentially there are so many of them, but you have here a list of the technical complications. So biliary complications, which are most commonly found in the split livers. However, they are treated effectively with radiological procedures or sometimes with the surgery. Vascular complication, the hepatic artery thrombosis. This is the most severe condition needing transplantation. The other vascular complications are managed if they are not associated with other conditions. In terms of life, after transplantation, well, of course, it depends on how it goes, but most of patients live in very good conditions. I have 3 examples here. This is an email I received from the mother of this girl. We have never met her after the transplantation, so she wanted to show us her girl. She is okay, she swims, she goes to the kindergarten, so we did not expect such a special, normal life. Then we have Graziano. He had another disease, so he had transplantation. Now he plays football. Now we have Teresa. She is the youngest child who received liver transplantation in Italy. So after 3 months of lung transplantation, now she's ready to use her bike. So very good results. So one additional information concerning the transplantation of liver and transplantation of hepatocytes, which is some of the possibilities we think of for the future. Well, you may know that hepatocyte transplantation has been made in some patients with no permanent or final success, but only with transitional temporary success. So it was then followed by liver transplantation. So the question is, if we have a hepatocyte transplantation, then we have a higher risk of liver transplantation in the future. Well, we may have portal hypertension, which is not a major issue. The patient receives immunosuppression. So, however, this is acceptable because when you do a transplantation after a first transplantation, the risk is a bit higher, but not so severe. But the real question is the following: do we really need a bridge procedure before liver transplantation? Well, we may say hepatocyte liver is useful to have more time. So to have more time before the liver transplantation, well, maybe to exceed the 6 months of the baby because of the child, because of course when you take the decision, then of course it takes more or less time before the transplantation is done, then of course we have priorities. There are difficulties in finding the right matching, particularly if the patient is below 6 kilos or over 35 kilos. And also we have to consider the availability of hepatocytes. First of all, below 6 kilos, I think there are no main reasons to wait for a child to be more than 6 kilos of weight, because basically there are no major differences if compared to the ones with lower weight. Maybe we need to do that to gain time. Well, in the Crigler-Najjar syndrome, I think it's not necessary because the allocation system in Italy states that these diseases we are talking about are in the 2B class. As you can see, this is a class after class 1, 1B, and 2A. So the children affected by these the diseases in the three previous classes are not so many. So if a child is in a waiting list, it will receive any possible offers of organs, regardless of the place, of the city where the organ is available. However, this has been implemented 2 years ago, so if you wish, really, the waiting time is so short and it takes longer to take the decision for the hepatocyte transplantation. And if you look at the data, for example, the wait list time was 120 days in 2011, and as you can see, 57 days in 2013 and 29 days in 2014. So the wait list time is short. There is no need for bridge procedure. In terms of weight differences between the donor and recipient, there are no major impacts in terms of final result. And finally, we have to bear in mind that for hepatocyte transplantation, we have first of all the need for donors with whole liver grafts rejected or unused for LT, segment for coated lobe from right extended split liver grafts, so we do not waste it, and excess tissue from reduced liver grafts. Of course, we do not, as I said, waste it. So, and there is also a very rare cases in which we can do it. Okay, so that's all for my presentation. I just would like to conclude with this paper. Quite provocative, and the title was "Too late to say it is too early: How to get children with non-cirrhotic metabolic diseases transplanted at the right time." So we may agree with the authors. They say that delaying the time for transplantation and focusing entirely on the risks and the post-transplant morbidity are contradictory. Because better clinical condition often results in better outcome. Secondly, transplantation carries risks, both short and long terms. This is a fact, but alternative treatments do as well, but there is less information published about the latter, of course. And for the last 20 years, it has been argued that liver transplantation for Crigler-Najjar, type 1 and similar diseases is unnecessary, as new therapies such as gene therapy and the hepatocyte transplantation are imminent. But it is hoped that gene therapy comes of age and radically changes the prognosis of these diseases, but it remains unlikely within the immediate future. So I think this is not true for the gene therapy any longer, but in this moment, so today, liver transplantation is the only practical way to change the outcome of the patients, and also to ensure a gene therapy, because if we want to have the effective gene therapy, we have to do that with liver transplantation. This, for the time being, maybe in the future it won't be the case any longer. Thank you. Any questions? My name is Anna. I have a 2.5-year baby with type 1 Crigler-Najjar syndrome. You know that for us as patients, we are kind of, scared, but I need to know something also bad about it, because it is very difficult for me to take a decision in a conscious way, because, it's like there are the ones in favor and the ones against the transplantations. But the ones dealing with transplantation don't tell the whole story about life after transplantation. So I really want to know what happens after liver transplantation, and maybe you're the right person to tell this. Well, maybe not me, but Dr. Danziga, who follows the patients. However, the first bad thing I have to say is that, liver transplantation offer 95% survival. In some cases, 100%, but 100% does not exist in medicine. So 0 or 100% do not exist. So we say 95% or 97%. However, there is a 3% mortality, and this is the first issue. Secondly, most of the complications I mentioned can be solved, but not all the time and not all of them. So there are some patients needed treatment. So most of patients do not need them, but some of them do need them. Patients having immunosuppression, most of the cases have to continue it for the rest of their lives. And so, of course, this open the door to infections or cancer. So monitoring is needed in this case. However, if all this is avoided, and I have to say that most of patients can avoid this, in this case, they can cycle, they can play tennis, they can climb mountains. So on one side, there is a risk, which is in the short term, higher than the long-term risk. But I think that the focus of the question is how, gene therapy is getting ready. So, because, 25 years ago, we started to mention the gene therapy, and we said, it would be soon ready, but, we're still here talking about gene therapy, which is not ready yet. Rossana, I would like to know something about liver transplantation in a 4-year child. When the child is 25 years old, he received transplantation 25 years before, but what happens in terms of expectancy or survival of the organ? Well, if the transplantation is done in a 4 years baby, then child, we think what happens in 80 years, but 80 years ago, transplantation was not possible. We know that transplantations were done in the 80s or in the 90s, and now the children at that time are adults. We know there is a risk of chronic rejection, which affects 2 children out of 10 transplanted. But in these cases, there are just few altered values, so we can treat it. And in 20 years after transplantation, only 3 children out of 100 need transplantation. In 60-year times, maybe, there are not 3, but there are more children needing transplantation again. But, in 60-year times, our knowledge will be much more as well. Ogni tanto accelera. I am type 2 Crigler-Najjar, and I would like to express my remarks. So I undergo phototherapy at night, and I live my life. If I undergo transplantation, I've been said that I have to be much more careful in terms of drugs because of the risk of rejection and all the drugs needed for the new liver. So my question is the following. So is it worth it? Because, now I can manage my disease independently, but it looks like that once I've been transplanted, I have to be very careful in terms of drugs, in terms of amount of drugs. Well, I wouldn't say that. I would say you have to be careful to pay attention to other things. So, of course, no phototherapy. So in this case, you would be more independent because you don't need phototherapy. However, we have to focus on other aspects. And liver transplantation, is not only one thing. So you have to consider the whole picture. So continuing the therapy for the life. So the transplantation is only one step. But it looks like gene therapy is soon to be available. So why undergoing liver transplantation? It's better to wait for the gene therapy. You're right, but we said the same thing 25 years ago, I have to say. There is a provocative statement saying that cellular and gene therapy are promising, and they will always be promising. All right, so thank you very much. We also have a special gift for Dr. Colledan. We have a last final question. Yes. In terms of transplantation, what parents or what the child has to do? So in terms of times, in terms of, we do not have enough information about this. So there is, of course, the assessment of the patient, which is twofold. So there are two main purposes. First of all, making sure that, the disease is present and we have the right indications for the transplantation. And secondly, during the assessment, we have to verify that there are no other conditions which would make it risky or more risky, and so in case special care should be taken before, during, and after transplantation. So after this assessment, then depending on the center where the transplantation is done, or depending on the child, so depending on the condition, then the patient enters the waiting list, and so there is the wait list time during which he or she has to follow the therapy. Once again, I repeat it, the allocation time is really short thanks to the new regulation. So it takes really days, not even weeks, sometimes weeks, but really it takes days. Then transplantation is done, and after it, we have of course, intensive care for a few days. And for most patients, this is done not because of the severity of the conditions, but very often it's because we do not have beds available in the ward. Then we have hospitalization time, which depends on the type of hospital, because if the hospital has a possibility to have like inpatient, then it depends on the hospital. However, hospitalization could be for 3 weeks. In case of complications, of course, it could be more than that. But the patients with a healthy liver usually do not have problems. And then, of course, you have to undergo periodical controls and checks, and over time could be like once a year, and exams or tests, and which can be done in their city of residence. Okay, I have another question for you. Curiosity about the auxiliary transplantation, because we had indication about the follow-up. Back at that time, it was months, sometimes a few years. But do you have any information about follow-up for a longer period? So if compared to full liver transplantation, how long it remains alive or vital? I mean, because this is often recommended as the ideal or preferred choice. Well, the problem of sort of competition between the two livers. Well, this is an issue. I do not have data, but today, when it comes to auxiliary transplantation, well, it is the choice for severe deficiencies. So really, these are the cases, and not really for metabolic, but also I mentioned the donor transplantation, which is quite fascinating. Also the so-called cross transplantation with no donor, but I would say this is sort of a niche application, so it can be used on all patients. I think we were all surprised by the intuition, or what? I mean, it's not us, I have to say. So we. It was published by an Indian group. So Mohammed Rela is the main physician, and they did that. So we wrote an article on that. So, but it was not us. So. However, in that article where that table was published, there was a specific message stating that could become the preferred transplantation procedure, for example, for Crigler-Najjar syndrome. So, however, that table was kind of doubtful, because we had cases of retransplantation. So, I mean, if this is the case, I would rather have a total liver transplantation. Yes, I agree. The additional risk is higher, and we take the risk if we think that another therapy is available soon. So thank you very much to Michele Colledan.